Here. So hello everyone and Falcha, or welcome. My name is Ahmed. I'd like to welcome you here to this webinar on the dental management of patients receiving biologic therapies hosted by the Irish Society for Disability and Oral Health. Thank you for coming. Thank you for taking some time out of your evening. Yeah, settle into your couches and your chairs, and it's sure to be an interesting, thought-provoking talk. Few housekeeping bits. Q&A section. You can ask questions throughout, and then we'll choose a handful at the middle of the webinar and at the end of the presentation as well to ask Dr. Sherwin. And then I'd highly encourage you to engage with the chat function if you to share your experience and your thoughts on how you manage your patients on biologics as well. And you can raise your hand if you have a question at the end. If you would like to, it's like if you have a longer question or one of your thoughts and experiences, it would be useful to have a dialogue as well. And then just familiarize yourself with your own functionality of your Zoom, because it can change depending on the platform that you use. And in case you're unaware, this is what the slide is about. The IADH, the International Association for Disability in Oral Health, they host a large conference every 2 years across the world. So 2 years ago, it was in South Korea. Very culturally different, and it was very enjoyable. And I'm sure those who went would say the same. Prior to that, it was Paris. This year, it's on our own turf here in Trinity College, Dublin. And then we're very proud of that. It was a lot of work just to get there. So the education committee and they're filled with the brightest minds in pediatrics and special care dentistry in Ireland, and they've created a wonderful, thought-provoking educational program that it'll just blow your socks off. Trust me, having seen it. And then the organizing committee, which I'm a part of, we've created a social schedule that will allow us here in the Irish community to really connect with like-minded people from across the world and gather and share special care stories and experiences and knowledge, because we all have techniques and tips and tricks to share, and it'll just be really, really beneficial to meet new people, meet new friends from across the world, and really celebrate Ireland's culture and heritage. And I know there's a lot of people tuning in from abroad. And I promise you, it's more than just Guinness that we celebrate in Ireland. And then the last great reason is the opportunity to present a poster and an oral presentation, which is what that QR code is about. So you can present on your project on an international stage, and that's open to everyone from students to dentists and to healthcare professionals as well. So just scan that QR code. And if you want to find out more, please follow our social media on ISDH. We're due to, the IADH are due to open registration any day now, and also inform you of the program as well. So please stay tuned. But anyway, enough about that. Back to the main event. So we're here to talk about the dental management of patients receiving biologic therapies, kindly presented by Dr. Emily Sherwin. So Emily qualified in 2007, and then she completed her vocational training in Derbyshire, after which she spent some time and escaped to Sydney in Australia, and then decided to come back and continue her training in special care dentistry between Thames Valley and London, where she received her MSc in Special Care Dentistry. Emily currently works as a consultant in the Department of Sedation and Special Care Dentistry at Guy's Hospital in London, and is the dental directorate dental oncology lead. And she treats a wide range of special care patients, including the use of conscious sedation techniques. And her particular interests are in dental management of patients undergoing oncology treatment, including the use of bisphosphonates and biologic therapies. Very fitting. And having worked with Emily while completing my training, I kind of always admired how she puts patients first, and really at the center of her treatment planning. I've just found that very admirable. And she has a very kind of unique methodical risk assessment process, which is really important for our patient base. And I know she'll go through that today. And it's been really beneficial in my training and in my career. And aside from that, she doesn't get much rest outside of work with family commitments. And we're praying this evening that her daughter doesn't pull the Wi-Fi router out of the socket this time. So with absolute fire away, Emily.
Thank you so much. I'm just going to get my slides over so we can all see those. But thank you for the introduction. That was incredibly kind. And it's really brilliant to be invited to come and speak about a topic that I really like to share my kind of knowledge and what I've learned over the years about. So as Ahmed said, my name is Emily Sherwin. I'm a consultant in special care dentistry in London in the UK. And for the next sort of 45 minutes with time for questions, hopefully, we can really unpack managing this patient group. And I think just to start off with, we're going to just have a little poll maybe to see how people are currently managing these patients. So I think Ahmed might just help us with that for the first portion. So yeah, I'm just really interested to just know how you're currently managing these patients, if that's something that you can manage where you are in your practice, or do you have another way of managing them to another service or working with your medical teams? So that would be really brilliant. We'll have about 60 seconds. And just to echo what Ahmed said about IADH, it's such a brilliant opportunity for us as a community of special care dentists to come together and share our knowledge and network and meet friends. So I really implore many of you to go along and have a really great time in Ireland. And congratulations to the team for putting on and getting ready for such a great event at the end of August. So yes, it's very interesting. We can see that a lot of people are liaising with medical teams, which seems extremely sensible. Some people are doing some dental care, which was also excellent. And very few of us actually referring to other services. So it sounds like we've already got a mechanism where we're trying to manage these patients. That's great. Thanks. We'll just close that. So I guess for me, the reason that I became interested in biological therapies was actually because I found them very overwhelming. When I was first starting to see patients who were taking these therapies, there were just lots of drug names. There were lots of different reasons they were taking them. I was confused whether I was supposed to be doing a drug holiday, what were the side effects. And to begin with, I thought what I'll do is I'll just learn each drug and I'll work out what I'm going to do for patients who are taking that drug. But it soon became really evident that there was just so many biological therapies and they were ever evolving, and I could never keep up with all of their names and what the patients were taking. So I realized that I actually needed to get a strategy and a way to work out how to treat any patient who's taking a biological therapy, actually almost regardless of what the biological therapy is called, but just thinking of ways that we can manage this patient group that really support us in our decision making. So I'm really hopeful that this evening we can update our knowledge in biological therapies. But most of all, I think I really want to try and inspire you and give you confidence in managing this patient group. And I do think that for us to be able to do this with confidence, we actually do need to have a little bit of knowledge about the mechanism of action and the use of biological therapies, thinking about their side effects, and then really thinking about how we assess and treat these patients who are taking these therapies. And I'm also going to just bring you to these SDCEPT guidelines that were updated in March 2024. I'm not sure whether you will have all have seen them, but this QR code that's on the screen links to that. And I think this is such a useful document that I just wanted to highlight it now, and I actually will highlight it throughout the presentation as well. So, what are biological therapies? We know that these are genetically engineered, usually from proteins from living cultures, and they're medicines that are made up of these biological sources. And we have some interchangeable names that we sometimes hear as well. So we can hear biologics, biological medicines, biopharmaceuticals. I actually prefer biological therapies. That's why we've used that today. But they are slightly interchangeable. So just make sure that when you're talking about biological therapies, everybody is talking about the same thing. Now, one of the reasons why we need to be interested in biological therapies is that their use has dramatically increased. In the last 5 years, NHS England has told us that there has been a 62% increase in biological therapies being prescribed in a hospital setting. And furthermore, 8 out of 10 of the most commonly prescribed drugs by cost in hospitals in England are, you've guessed it, biological therapies. So we need to be interested. The other thing that's also really interesting about the trajectory of biological therapies is that many of these drugs were actually developed many years ago. They were on patent for several years, and they've now actually come off patent. And this has allowed for some really similar medicines, we call those biosimilar medicines, to be developed, which are very, very similar to the original biological therapy. They have the same quality, they should have the same efficacy for treatment of disease, and they should have the same safety profile too. But the key thing is that these are often less costly, so they're cheaper than the original biological therapy. And this is helpful when we think about the fact that these drugs are being used at an exponential rate. And we know that the healthcare systems are under such a lot of financial burden. So it's interesting to see that these biosimilar medicines are being developed to help reduce those costs and hopefully with very limited change in the disease treatment profile. This is just an interesting bit of information I found about the Medical Act in Ireland, which does explain that you can't just interchange biomedicines. And what that means is that patients who are currently taking biological medicines, they won't suddenly have their drugs changed for a biosimilar drug, even though they might be cheaper. The cases where a biosimilar medicine will be thought about being prescribed is if a patient is going to start a new medicine or if they are thinking about changing their current biological therapy because of the disease, because of the side effect profile. So there's more information about that. That's linked there if you want to know any more about that. So I do think for us to fully understand biological therapies, we just have to have an idea about some of the mechanisms of the very common ones that we're going to come across. So we're going to just have a think about some of those ones that we definitely are going to see in our practice. And many of us will have heard of monoclonal antibodies. These are the drugs that are used to bind to cell surface antigens and then to block some of the signaling pathways, maybe growth, maybe division, maybe try and promote cell death. And they can also be used to deliver cancer treatments. And I just want to remind you that not all monoclonal antibodies are created equal, and we would not expect all of them to have this side effect profile and particularly cause hemorrhage that I think we are quite concerned about based on their mechanism of action. So as we unpack further these different drugs, we're going to see those ones that we need to be more in tune to and to be more aware of. So denosumab, I do expect that you may have heard of this drug. They have the suffix mab when we know that they're a monoclonal antibody. And this is a rank ligand inhibitor. It prevents the formation, the survival, and the action of osteoclasts. And that's all aiming to prevent bone resorption and maintain bone density. And that's why we know that it's used in the bone treatment, so osteoporosis, metastatic cancer to the bones, and giant cell tumours of the bone as well. Now, in this presentation, I've really highlighted to you those drugs that we think have an association and known to be causing hemorrhage, not in all cases, but really can cause it. And they're highlighted in red. So we can see denosumab, we know that does have associations with hemorrhage. And we can also see that it's got two different dosings. We've got 120 milligrams or Prolia that has 60 milligrams. And the higher dose is often given monthly for the metastatic cancer treatment, and the lower dose is given usually 6 monthly, sometimes annually, for osteoporosis. So we're already starting to build up a picture of different level of risk. We can see that the doses are different, the regimes are different. So the new kid on the monoclonal antibody block is romosozumab, and I really wanted to share with you about this new drug. It's a sclerostin inhibitor. So what sclerostin does is it actually is a disruptor of the bone formation pathway. So romosozumab is a sclerostin inhibitor, so it means that the bone formation pathway can remain open and it continues for us to have bone formation and maintaining our bone density. And that's why it's used in the treatment of osteoporosis in specifically postmenopausal women with severe fractures, usually in the last 24 months. And it's given as a monthly injection over 12 months, so that's sort of 12 injections over the year. And this is the bit that is interesting. It is often followed up by an anti-resorptive therapy such as denosumab. So we can see that romosozumab is in purple, and this drug has a possible association to MRONJ. But we can see that the regime then adds in a drug known to cause MRONJ, denosumab. So some other mechanism of actions of some monoclonal antibodies that I just wanted to highlight to you are those of the anti-angiogenic drugs. So these are often binding to the vascular growth factors and trying to prevent the growth of blood vessels within tumours. And that's why it's used quite commonly in the cancer setting and often used in a combination with chemotherapy. So bevacizumab Avastin, again, is in red. So this is highlighting the fact to us that it's a known association with MRONJ. And for this time, this is to do with vascularity and blood vessels and blood flow. And then we're going to have a look at the tumor necrosis factor inhibitors. So what happens here is that these inhibitors bind to tumor necrosis factor alpha, and that's normally a protein that's promoting inflammation within our bodies. And so these TNF inhibitors actually bind to that and prevent them from going onto cells and activating the kind of immune response that we see, often causing a lot of inflammation. And that's why these drugs are used to treat the inflammatory diseases in rheumatology and so such as inflammatory bowel disease as well. And these are things like adalimumab and infliximab. So the next group of kind of biological therapies that I just want us to be aware of are the fusion proteins, where these two genes are brought together to enhance a protein to treat a specific disease. And again, you'll see some repetition as I'm building up a picture of why we might be concerned about these drugs. So again, some of these drugs are preventing that endothelial growth factor, trying to prevent the growth of the vessels within cancer tumors to try and shrink the cancer. And the ones that are also attaching to the TNF proteins to block the inflammatory pathways. So that's why they're used in the vascular macular degeneration and colorectal cancer. And then the TNF is used for the rheumatoid arthritis as well. And abifilostat, that is again in red. So we know this is a drug that is known to cause MRONJ, and etanercept is in purple. So this has a possible association. So the other key signaling proteins that we want to have a little think about are tyrosine kinase inhibitors. They're aiming to disrupt the cell signaling. Often that's growth factor, trying to prevent proliferation, metastases of cells. And this is often in either an anti-angiogenic way or an anti-proliferative way, and therefore they're used in cancer treatments. So again, we've got multiple drugs that are in purple, but the one that we really want to think about is sunitinib, which is often used for renal cell carcinomas, and that is one of the other drugs that has a known association with MRONJ. And just our final signaling protein that we're going to have a think about is the mTOR inhibitors. So these are aiming to block the signals within mTOR, and that's stopping the protein synthesis, which is then preventing cell proliferation, cell growth, again, the angiogenesis, so trying to prevent the growth of these blood vessels and disrupt kind of the glucose uptake and the energy that cells need. Again, used in in cancers, but also actually used in transplantation to try and prevent rejection. And everolimus, temesirolimus in purple, okay, so they've got a possible association with MRONJ. So just having a little look at those mechanisms of actions, hopefully sort of unpacked why we're starting to think some of these biological therapies do need some key management when we're going to be doing dental treatment. So we also know that these drugs are very useful in treating a number of different conditions, but they do have side effects. And those systemic side effects can really range from having quite severe allergic reactions, anaphylaxis, maybe some skin reactions, perhaps at the site of the injection or the infusion. We know that some people can have an autoimmune kind of liver response where their liver becomes impaired, and that can then feed into having bleeding tendencies, which of course we're going to be very interested in. They may be more prone to opportunistic infections, so viral, bacterial, fungal, and there can be some electrolyte imbalance as well. And we know that cardiac symptoms can range from those such as arrhythmias or the major adverse cardiac events such as myocardial infarction or even heart failure. There was a recent meta-analysis that suggested that the short-term use of biological therapies isn't thought to cause major adverse events, but kind of longer term, it's actually unknown whether maybe they do cause some problems. And so further research is needed to follow people for a longer time period who are taking these medications. And we're, of course, interested about the oral cavity and the impact that these medications may have on someone's mouth. So we know that they may be prone to these opportunistic infections. We know that there may be oral ulceration, mucositis, the sort of start of the GI tract problems that we know are also systemic effects. People can have dry mouth, which can then lead to a higher rate of decay, may have a lot of altered taste in the mouth as well. And of course, our big concern that we've been thinking about, even from the start of this presentation, is the side effect of medication-related osteonecrosis of the jaw, which I think I allude to as MRONJ most of the way through this presentation. So I think we were just going to check in and see if there were any major questions right now. I think if there's anything, Ahmed, that anybody wanted me to just clarify, you can sort of let me know.
Thanks, Emily. So far, so good. Everything's looking great. I think we're okay for questions at the moment. I'm kind of answering one or two kind of questions on the side, but it's not particularly pertinent to the presentation. So I think we're happy to crack on if that's all right.
Yeah, definitely. Thank you. That's great.
Thank you very much.
So we've had a little bit of a background about biological therapies, but the reason you're actually here tonight and the reason that you've taken the time out to come and see this and not watch something else or do something else is actually because you want to know how do you manage your patients who are taking biological therapies who need dental treatment. So this is really the stepwise approach that I take to managing these patients. And it's just thinking in a really methodical way, how am I going to treat this person by getting a really thorough assessment that I'll just go through shortly, thinking about the risk of the biological therapy and then minimizing the risk, but then having to manage some level of risk as well. So this probably is the most important slide of the presentation, I would say. So please just have a look at it. I think we have to take a really, really thorough history and do a comprehensive assessment of patients who are taking these medicines. So we do need to know what the drug is. We need to know when it started. We need to know how long are they going to be on it. Is it for indefinitely? Is there a defined period of time? What's the current regime? And I've just written here a little bit about the half-life of the drug. That's quite difficult to find out, and often the patients won't know, but we'll have a little look and think about ways we could maybe find out about the drug. The other thing that's very, very useful to understand is how often is this patient being monitored while they are taking this medicine? What are their review intervals? How often are they having blood tests? And what are the results? And are there trends that are you can see in their patterns of the blood test results? We know people who are having very frequent monitoring are probably less well controlled. Those who have very regular tests obviously have some systemic impact that we need to be aware of. And does the patient have any side effects that they experience, and they can tell you about those? That again will give us some idea about anything that's underlying. Someone who is having a lot of bleeding or a lot of bruising, we're going to be concerned about the impact on the platelets, for example. And have they been on another biological therapy? That's also important to just consider, because it may be that they very quickly or very recently changed and actually they were on another therapy previously. So just have a think about that. And then just make sure we understand why they're taking that medication and what else is in their medical history. Is there anything else that we need to be really aware of? Maybe running through a systems examination. Think about other ongoing treatments they have for those conditions as well. And thinking a bit about other concurrent medications. These are all things that are going to have an impact on healing, maybe have an impact on the MRONJ risk, so steroids, bisphosphonates, methotrexate as well. And who are you going to get in touch with when we say we liaise with the teams? Who are we going to get in touch with? I often find the clinical nurse specialists are really useful points of contact, but make sure we have the details and make sure we know how to get in contact quickly and easily. And do they carry an alert card? Some patients do have an alert card that says, I'm taking this biological therapy. If I am to have an infection or have invasive treatment, I need to be dealt with in this way. So that's helpful to know as well. And then just some other information that always helps me build up a picture of the healing profile, smoking status, alcohol, nutritional status as well. So a comprehensive examination is really going to help us to understand where the risks are and where our concerns should lie. So when I think about then the risk of carrying out invasive dental treatment for a patient taking biological therapies, I think about it as a triad. I think of their bleeding risk, I think of their infection risk, and I think of their necrosis risk. And actually, I'll let you into a bit of a secret. I actually use this for all my patients, regardless if they're on biological therapies or not. These are the three key things that I am interested in when I'm planning care for patients. So how do we find out the risk? We don't always know what the risk is for each drug. We know that there's many drugs, there's new drugs, there are drugs that people will be taking that we'll never have heard of before. And we need to work out, how do we find out more information about those medicines? So we can use sort of online kind of methods. So this is the Irish Medicines Formulary that I expect many of you are used to using. And then over in the UK, we use the BNF. And then we have these guidance documents which highlight to us where there is concern or where we need to be thinking about acting in a certain way. And this is just an example of an alert card which somebody may have to kind of identify when they may be at risk. And I found more recently that some of these sort of cancer information websites have got a fountain of information. They've got a lot of information about specific drugs. You can search the name of the drug, you find out about the side effects, and that can be really helpful as well when we're sort of thinking about what the impact for this patient may be. So here we are, back to MRONJ again, and just to highlight the supplement edition in March 2024, the Scottish Dental Clinical Effectiveness Programme, they updated their 2017 guidance by adding a supplement. So they actually didn't change that guidance, they just gave us a bit more information. And again, I've just got this QR code because I just really want you to be focusing on this to help you understand about MRONJ risk in your patients. So one of the things that they did update was about the incidence of MRONJ. And very interestingly, they actually increased the kind of estimate of incidence in cancer patients to less than 5%. And previously, this had actually been 1% in the document in 2017. But also interestingly, and sort of conversely, the osteoporosis patient risk or incidence, was cited as less than 0.5, whereas previously it had been up to 0.1. So we can see that the incidence rate in cancer patients of MRONJ has increased or has been thought to be higher, whereas in osteoporosis patients, it's actually thought to be lower. And I think this is probably because we have become much more aware of MRONJ. We are better at diagnosing it, but our medical colleagues are also much better at highlighting to us if they think there's any problems. And I also think there's a bit more patient awareness as well now. and people are prepared to monitor things for longer. And why do we think that there is a higher incidence now for the cancer patient group? And I think that's probably an example where people are having more treatments. So there's further drug combinations. They're having multiple lines of treatments. Hopefully that means that they're surviving longer and having a higher cumulative dose of drugs as well. So this is the table that they have set out to say the drugs that are known to be associated with medication-related osteonecrosis of the jaw. So we, of course, have bisphosphonates, which are not biological therapies, but we have to just include them when we're talking about MRONJ. But down at the bottom, we will recognise those four names. So we know denosumab, we know bevacizumab, we know sunitinib and aflibercept. We've already talked about those earlier, and we understand that they can cause MRONJ. And we know that MRONJ is difficult to work out exactly what's happening, but it's definitely a combination of pathophysiology, such as the problems with infection and the bone not being able to heal. And I think that plays into this kind of the drug setup where it's affecting bone, but also affecting the vascularity of tissues as well, so that we know that the healing may be impaired in that way. And this is really what the update has given us. These sort of secondary group of drugs, biological therapies mostly, which have a possible association with MRONJ. So SDCEP did some more research looking at all those times that MRONJ had been implicated in patients taking drugs such as these. And we can see that these are the families of drugs that we have been talking about. We've been talking about the protein kinase inhibitors. We've looked at our monoclonal antibodies and looking at our tumor necrosis factor inhibitors as well. So the reason that I wanted to share with you the mechanisms of action of those drugs at the beginning was for us to understand that those are drugs that we need to be considering having some risk associated with MRONJ. And risk is not straightforward. It definitely falls along a spectrum, and that's how I like to think about it. And sometimes we need to look at how we're going to stratify the risk for our patients. This is one of the flow diagrams that are used in the SDCEP guidance. Again, it's very much talking about bisphosphonates as well as denosumab. But again, we're talking about having this risk profile. So is the patient on a medication for cancer, and that puts them in the higher risk group, or actually have they are they just taking denosumab, or they took it last 9 months ago, puts them in a lower risk group, or perhaps even no risk. So just trying to work out how we can stratify risk for our patients. So we've assessed the patient, we've identified the risk of the biological therapy, and now we need to think about minimizing the risk for our patients. So I think one of the key things is having a think about the timing in the biological therapy regime. And that's why I was talking a little bit about half-life, because we do know that how frequently the drug is giving us some indication to the half-life of that medication. So a biological therapy that's taken daily is going to have a very short half-life, probably of hours. But one that's taken monthly is going to have a much longer half-life, maybe of weeks. So it's useful for us to think about whether there would be an appropriate time within the regime to do dental treatment. Are they taking things 8 weekly? Can we carry it out towards the end of their kind of 8-week cycles? Or are they actually going to have a therapeutic break? This is quite common more in the cancer treatment field, where perhaps they have a break of treatment, ready to have scans. Is that a good time for us to carry out some dental treatment? And we're talking about invasive dental treatment here. And what is urgent? What is elective? What are your options? Do you really need to take out that retained root that is asymptomatic, that the patients have for many years? And actually, we need to be pragmatic about the impact of taking out a tooth where a patient is not having a problem. But conversely, we need to be really ready to try and support our patients who are having a lot of dental problems. We know how debilitating that dental pain can be, and we do need to try and support these patients patients to have dental treatment if they are needing it. And that's when we need to liaise with our medical teams. What can we do? When should we plan this? What other things would you like us to think about for this patient? And it needs to be thought of in a really sensible discussion with the patient about risk versus benefit. So we need to make sure that we're going to be providing some level of benefit for the patient. We know there is going to be some risk of taking out teeth on a patient who is on a biological therapy. And so we need to be clear with them the reason why we're doing it and what we're hoping to achieve by carrying that out. And I've already alluded to this as well, but it is a spectrum of risk. And I sometimes say to patients, it's not as straightforward as saying you're high risk or low risk. And these are the reasons why I think you're in a moderate risk category. We know that you're on steroids, you're on this medication, you're smoking. And we're just trying to think about where the risk profile for this patient falls along this long spectrum. So something that I have also found quite interesting is what are the medical teams suggesting? And of course, it's not clear what we should be doing exactly, but there's some ways that we can try and formulate in our mind what would be a sensible or a useful way to manage these patients. And one of the things that we need to think about is the half-life of the drug. And the British Association of Dermatologists, who have an excellent acronym of BAD, that is really excellent, they have suggested in this position paper from 2020 for people having, this is medical surgery, it wasn't actually talked about as dental surgery, but it was medical surgery, that they think that these drugs should be stopped for 3 to 5 times the half-life of the drug. So this is interesting. I'm not saying we have to do this in dentistry, but it's just helping us to understand why we might stop a drug or thinking about the things to consider about the half-life of a drug. So we can see, for example, infliximab, it's got a half-life of about 9 days. So we would probably want to be stopping it for a few days if that was going to happen. But etanercept has a shorter half-life, so perhaps we could think about stopping that for a shorter period if that is what we're agreeing with the medical teams. So it's just helping us just to think about the half-life and how that might help us in the planning and the timing, really, of doing dental treatment. So this is a sort of a recommended table of advice that down at Guy's we've actually produced for our rheumatology colleagues. There was a lot of times when they were saying, oh, this person's had a filling and we're not sure whether we need to stop the next dose of romosozumab. And we wanted to be very clear that where possible, the dental treatment would not impact on the regimes that people were having for their treatment. But you can see that we have had to think about denosumab and romosozumab, and actually whether we, particularly for romosozumab, skip the dose prior to the extraction and then allow 4 weeks of healing. And again, allowing some weeks of healing for our denosumab for those patients having an extraction as well. And it's very difficult because everybody is different. And I am seeing more commonly some patients who are really not healing very well in 4 weeks. Those patients who have had maybe a molar extracted, there's been some level of apical pathology, but not that much bone loss previously. And to have some degree of bone modelling, that doesn't really happen in 4 weeks. And so perhaps you need a longer period of healing before the drug is restarted, or at least to think about the risk of restarting it. So we've thought a little bit about trying to minimise the risk, and we're going to have to take on some level of risk because, as I've already said, people will need dental treatment who are taking biological therapies. So we need to have a think about how we manage that risk. So again, we're thinking about the timing, both in terms of their biological therapy cycle, but also thinking about those with a bleeding risk. We're doing that earlier in the day, earlier in the week. We need to remember about their blood trend profile. And if there's somebody who we know they can have low platelets, thrombocytopenia, maybe quite regularly throughout their treatment cycle, we need to be having a full blood count before we do the extraction on the day. It may be useful to have a coagulation screen or a liver function test. I often find that if you have a good trend view of these and it's been very stable, you don't need that so acutely on the day. And often we forget that actually local hemostatic measures are really useful in trying to prevent bleeding problems, and people having post-operative problems, which then can cause, quite a lot of concern about their healing, and make them more anxious about having dental treatment in the future. I have a very low threshold for packing and stitching. Again, many patients. We know that many of our patients don't want to have post-operative problems and will find it very difficult to access care should they come across that. So I think it's very useful for us to really consider that on a very regular basis, actually. So the next part of managing infection is thinking about, again, timing of treatment within their cycle. Do they have any signs where they've had neutropenia in their blood trends? Do we need to be doing a full blood count on the morning of our extraction appointment? Do we need to check their neutrophils? And then we need to have a think about whether post-operative antibiotics would be appropriate, particularly in those who are taking biological therapies where we know there's going to be alterations to their immunity and their kind of inflammatory response as well. And I use amoxicillin 500 milligrams. I did have to look up to see in Ireland what your prescribing guidelines were, but I can see that it's along the same lines as ours, and I think that's really very reasonable. And I know that there is not a lot of evidence for post-operative antibiotics in the kind of patients sort of prophylactically, or we're going to go on and talk about MRONJ. But I am very pragmatic in the sense that having some antibiotics after an extraction where you are of risk of either infection or MRONJ feels to me very reasonable and sensible, because we know that people who go on to develop MRONJ often need to be on antibiotics long term. So I feel like having a really short course after an invasive procedure with a kind of defined risk and with discussion with the patient, I feel that's a sensible way to approach it, to try and prevent a longer term problem, which then needs a longer term kind of treatment with antibiotics. So how do we manage MRONJ risk? And I know previous speaker Harry has spoken quite a lot about this, but these are the things that I do on a really practical level. So we want our patients to have the best oral hygiene that they possibly can before we carry on with our dental surgery. That's often difficult to achieve on a very short term, but trying to provide them with a personalised preventive advice. I think one of the ways that we can do it is saying to them, for you, brushing your teeth twice a day is going to be making a difference. Trying to empower them and give them a sort of short intervention to hopefully change their behavioural habits. One of the things that I also like to use is a low adrenaline local anaesthetic. So I'm looking at using articaine 1 in 200,000, just trying to have some level of vasoconstriction, but we also want to keep blood flow in the area. Again, we're coming back to the fact that we know trying to keep good vascularity is helping our patients to heal, trying to reduce the risk of infection, and then driving the potential kind of pathophysiology of MRONJ. So for our patients who we are carrying out an extraction, and maybe for those who are much higher MRONJ risk, so our metastatic cancer patients who are having high doses of, for example, denosumab, we may consider an alveoplasty. So we would do the extraction first, then you would raise a flap, take down the alveolar bone that you can see to try and help and promote healing, and then where possible to close that area with primary closure with good sutures. And again, I've just talked about post-operative antibiotics. I will give post-operative antibiotics for patients who are at risk of MRONJ. And that group where it's a possible association, I think I'm leaning more towards giving it, but it's again a risk-benefit kind of thinking about it, and maybe the impact on their systemic disease as well. And it's always ideal to allow a healing period if we can before starting a biological therapy if we stopped it. There are some places now where they're trying to keep the patient on their biological therapy because we know that the benefit for their disease control probably outweighs the problems that they may have from their teeth. But again, we've got to decide on that on a case-by-case basis. And we want to be reviewing the socket at 8 weeks. We know that's the definition for MRONJ, where we have kind of the exposed bone or the non-healing socket at that 8-week post-extraction point. So I guess the question is there a way to remove risk completely? We're not risk averse, but we would like to reduce our risk if we can do. And I think the way to do that is obviously to have a dental assessment prior to your biological treatment. It sounds brilliant in theory. In reality, it's very challenging. But there are some key biological therapies where people are being signposted to have a dental assessment. And we know why they're going to be these key ones. It's because they're the ones that are known to be associated with MRONJ. So this obviously talks about bisphosphonates, but denosumab, and then MHRA have talked about bevacizumab and sunitinib, where they suggest that people do have a dental examination before commencing these treatments. So if we see patients where they are already taking, where they're due to take biological therapies, what should we be thinking about when we're planning some care for them? And it's hard because we don't know the teeth that are going to cause them problems. It's difficult to think about the kind of longevity or the prognosis of the teeth that are in front of us. But we know that there will be poor prognosis teeth, perhaps retained roots, or the teeth that are already causing the patient a problem. It's ideal to try and stabilize or optimize periodontal disease. We know that's a chronic inflammatory process that it's not easy to treat in just 1 or 2 visits, but can we optimize that in any way possible? And often that's by trying to improve oral hygiene habits. Is it worth thinking about improving, replacing dentures? Do we need to get a better fit of the dentures to try and prevent any areas of trauma then causing exposed bone? And you can think about the high fluoride toothpaste prescriptions in that high caries patient. And of course, trying to signpost to our smoking and alcohol cessation teams as well. So I think we're sort of coming towards the end. I've just got a case study for us to finish off with, and then we're going to just take any questions. So this is a patient who has been referred to me for dental extractions of unrestorable teeth. They have Crohn's disease. They have anemia, which is possibly a link to the Crohn's disease. There might be a lot of blood loss from that. They're on azathioprine. They're on infliximab 8 weekly, so once every 8 weeks. They're also on the ferrous fumarate, so trying to be iron replacement. And it's quite interesting, they were taking a different biological therapy before they started their infliximab, which is already ringing to me that there's maybe some difficulty in controlling this disease. And they don't have any allergies, but they're advised to avoid NSAIDs because of the impact on their GI system. So again, I'm going to use my assessment to make sure I have all the information that I want. I'm finding out about the infliximab dose. She's been on it for the past 9 months, taking it 8 weekly, and I've worked out that the half-life is about 9 days. She has a pharmacy monitoring monthly. She has a clinic review 8 weekly with bloods as well. But she's still having some symptoms, some GI symptoms of her Crohn's disease. And we know that's why she's changed her biological therapy to see if she can get better disease control. We've looked at the other medications. We know that azathioprine is also quite immunosuppressing as well. So that's going to be concerning us. And we know we've got anemia as well. So that's going to be thinking about some concerns with healing as well. And she doesn't have alcohol or smoking, and there's a low fiber diet. And so these are her blood tests. She's having the 8 weekly blood tests, so we can see the blood profiles. We've got the hemoglobin there. We've got the platelet count. We've got the neutrophils, and the liver function tests were always normal, so just put that as normal there. And we can see there is a kind of slight trend. At times, it feels like the disease profile is maybe better controlled. We can see month 7, there's higher hemoglobin, higher platelets, higher neutrophils, obviously trying and fight the kind of infections there. And then it just gently falls back down slightly, but it's always within normal range all the way through. So I feel quite confident that this patient has a quite stable bloods at the moment. So I think we are going to just have a poll and just see about what we think that maybe we should prioritize when we are managing this patient. So, is it that we should focus on some bloods and some antibiotics, the timing? Do we need to actually refer to another dental service, or would we just manage this in a completely different way? So Just interested to see your thoughts on how maybe best that we would manage this patient. So we'll just have a few seconds there. I'll just take a quick drink. The results come up and show us. Oh, here we go. Yeah, okay, interesting. Yeah, I think I agree with you. All of the answers are really valid, but yeah, I think timing of the treatment and referral and liaison, sorry, with the gastro team is really, really sensible. And we'll just come on to the next slide where so yeah, I think I really agree with you. I think we want to prioritize the timing. We know this is an 8 weekly regime. So actually, should we take the teeth out at week 5 or 6? Then we have maybe a 2 week period of healing, 2 to 3 weeks of healing. We know these teeth are unrestorable. They're symptomatic. We really do need to do this treatment. And we need to have a thorough discussion of the risk with the patient. And I think I can not underestimate a really good, thorough discussion, being really honest with them where we think there is some level of risk. I think we would talk about a possible risk of hemorrhage with infliximab. Again, infection and bleeding is some level, but we know that the blood trends have been very stable and we can use our local measures. We know that the neutrophils have been in range. And we know that the hemorrhage risk, I think, is probably the higher risk out of the three. And that's why I think it's good to ask the question of gastroenterology. What would they like us to do? Would post-op antibiotics be appropriate? But remember, she still has a lot of GI symptoms, and actually, is that going to really kind of upset the balance for her there? So it may be that actually the timing is what we focus on, and we don't give post-operative antibiotics in this case. So I think I've really hopefully summarised all these points and just given you sort of a stepwise approach. We've talked through how we assess these patients. We've thought about our trio of risk, our bleeding, our infection, our hemorrhage risk, and thinking how can we try and manage risk and minimise risk for our patients when we're doing dental treatment for them. There are some references here. The top one is a paper that I wrote with my colleagues, Hannah and Miriam, where it really covers everything that I've covered tonight. So that's a really good paper to maybe have if you want to have some more information about this. And then some other references there. There's also these guidance documents that I've alluded to throughout. So we know our SDCEPT, also the UK Chemotherapy Board had a great document back in 2019, and some information about biological medicines and biosimilar medicines, and then the online resources that I've also talked about as well today. So this is my email. I'm very happy to have anyone email me, but I'm really happy to take questions right now as well, if that could be of help.
Fantastic. Thank you so much, Emily. Connection was smooth throughout. I'm very, very glad to see and reassured. So that's great. Yeah, I think that was a very kind of simplified, kind of very straightforward way to present biologic therapies. When kind of people generally, in my experience, when they present with biologic therapies, your mind just goes racing to lots of different areas. But I think coming back to how you risk assess patients, it just really simplifies the process and makes it very stepwise and very manageable. So thank you very much for sharing your secrets of practice.
They're not that secret, actually, it turns out, but
yeah. Yeah, just the kind of the pragmatism involved caring for the patients, I think is what stood out, what really stands out in your care for them, both in terms of kind of treatment planning and also in terms of antibiotic prescribing. So thank you very much. I'm happy to take questions, so please feel free to put pop the questions in the Q&A box or in the chat box, or if you want to raise your hand, please let me know. We'll take a couple now. So there's a couple that came in relation to the setting in which you do this treatment and the acceptance criteria for each. So the first question is, in a dental hospital environment, what's your acceptance criteria for a dental screen prior to biologic therapies, especially if you don't have the capacity to screen everyone? And the second question kind of echoes that, but in a community service setting. So what are your thoughts, Emily?
Yeah, so it's tricky, isn't it? Because we don't have never-ending resources. So I think we need to be screening high-risk patients. So in my area, we see patients who are going to start denosumab therapy and actually bisphosphonates for metastatic cancer. We know they're going to have that on a monthly basis, and soon they'll have had 12, 14 doses in the next year. So that's who we would screen. We do also have referrals for the other medicines, so sunitinib and bevacizumab Avastin. Those drugs have a shorter half-life, so there often becomes a window of taking out teeth or doing dental treatment if they discontinue that medication in the future, which often we don't know, but the half-life and the kind of longevity of the effects of the drugs are not quite as kind of long as bisphosphonates and the denosumab as well. I think that in a community setting that we can definitely be screening patients who are maybe going on these medications for inflammatory bowel disease. That's kind of a lower risk. And we're not even saying that we necessarily have to do treatment right now for them or stop their treatments. But it is about service, it's about provision. There's actually no reason why somebody who sees their local GDP, their local dentist regularly, they're about to start a new medication. There's no reason why they could not have their routine dental checkup, and that actually forms their screening. I think you've got to remember those higher risk patients where you're having to make the difficult decisions. They often need to be seen in a more kind of hospital setting. And that's often not because we say anything different, but it's often because we actually say less, because we know that these patients, they need to start their cancer treatment. They have a priority of receiving their life-prolonging treatment, and we need to be pragmatic. You already know I'm a pragmatic person, but we need to be realistic that some dental disease may actually need to be left while they prioritize their cancer treatment. And that can be a difficult decision to make in a primary care setting where that's not what we're used to making. So I think when the stakes are lower, then the primary care setting is really useful. I think when the stakes are higher and the risk that you're prepared to take on becomes higher. And I'm prepared to take on higher risk in the setting where I work, because I can then talk with my oncology colleagues and say, actually, I think we need to do it this way or this. And they'll say, actually, we need to start their chemotherapy treatments first. And I can work alongside oral surgeons. And so I'm in a position where the high risk patient can be managed in a multidisciplinary setup.
Thank you very much. Emily, I had another question just on the back of kind of liaising with the oncology team. What sort of information do you discuss or request from the medical specialists when discussing oncology patients needing extractions who are on biologics? I know you slightly alluded to it in the presentation, but it'd be interesting.
Yeah, so I mean, obviously we're going to take our assessment. I think we need to have a really good kind of dialogue, and I think prognosis is useful to know. I know they often are not using kind of months as prognosis anymore, but they may give an indication, and we can also work out how the patient is responding to treatment. Are they on their third line cancer treatment? Do they have multiple metastatic disease, including, you know, sort of skull metastases? It's all giving us a picture of the kind of prognosis for this patient, and then whether actually a dental intervention is appropriate at this stage, particularly if they're asymptomatic from a dental viewpoint. So a good dialogue is really good. And we've sort of started to learn that they often say to us they must have 6 rounds of their planned chemotherapy, immunotherapy before we start denosumab. And then we say, okay, well, either we then proceed with the denosumab or we see them for their extractions and then they start. And I always say I don't want dental to be a reason why someone doesn't have their medical treatment. So it may be that they have to, or they need to start their anti-resorptive therapy, and then we need to just manage the consequences, whether that be more like symptomatic relief or even antibiotics during cancer treatment, for example.
Thank you very much. It's fantastic. You have such a close working relationship with your oncology team, but unfortunately, not every
I
establishment
know.
shares that relationship. So another question that came in is,
Mm.
how do you manage cases who don't get a response, where you don't get a response
Mm.
in a timely manner? Do you proceed on your own assessment, or does, but this then may leave you to open to criticism? Um,
Yeah.
and when is there, what's the consequence to that delay of treatment?
Yeah. Yeah, and actually, I didn't say this, and I was going to say it, is that I now often present to the medical team what my plan is, and could they please tell me if they would not like me to do it in that way? Because although the medics know the patient, obviously their medical history, we really do know about the dental problem. We know about the risk. We know about why this person needs dental treatment. So I think I support what that person is saying, that I actually probably would proceed. But remember, in the setting where I am, I'm going to take on that level of risk because I'm in a tertiary centre with my colleagues that I can discuss the case with. So my consultant special care colleagues, I perhaps talk with them about it and say, look, we're not getting any further with the medical teams. This is my kind of sensible approach. Does that seem reasonable? So it could be that you share the risk or share the consideration for that person. You have to decide the risk benefit. I think I would support people, if people are coming to see us and they're in dental pain and we're needing to make some decisions, I think we can go ahead with dental treatment if we've really thought about the risk and discussed it with the patient. The other thing is be truthful. I'm not hearing back from your medical teams. Do you have any way I can contact them? Or I can see how much pain you're in. Do you think we should proceed with this one extraction with some measures, perhaps antibiotics, review you, and then for the other dental treatment, let's see if we can get in touch with your medical team. So a pragmatic, risk-balanced approach, yeah.
Yeah, with informed consent, exactly, with the patient.
Exactly, yeah.
Thank you very much. A couple of other questions. Do you do you have any experience with kind of platelet-rich fibrin, or do you think LPRF is useful adjunct in this patient group? Yeah.
Yeah, so I don't personally use it, but my oral surgery colleagues do. Yeah. Yeah, so I think it has been used, but I'm not really best placed to talk on that. So maybe someone from oral surgery would give some advice. But yes, it has been used in the cases where they're wanting good healing after extractions. Yeah.
Thank you. If there is anyone who is interested in
Mm.
commenting on that, that'd be interesting as well. Thank you in the chat box. Would you consider stopping methotrexate for 2 weeks after an extraction in the same way?
Yeah, so methotrexate, that's beyond the realms of biological therapies, and I think it's a really tricky one. I would consider, but again, people usually have very good control with their disease on methotrexate, and you suddenly have an interruption that really changes the disease profile. So I probably would not stop methotrexate without talking to the medical teams. That's one where I think that we need to really understand the impact that stopping it may have. So yeah, no, I wouldn't actually stop that without discussing it.
Thank you. This is just a kind of an opinion. I work in community and find multidisciplinary care can sometimes be disjointed and challenging, e.g., obtaining timely blood results, delays in correspondence.
Mm.
I would echo that as well,
Mm.
having worked in community. I think kind of, I suppose, my experience is dealing with the CNSs are like Emily you alluded to I just find them to be far more timely, and actually the CNSs are the ones who know the patient
Mm.
best, I've found, and they would have kind of the best possible connection, or you would have the best kind of chance of
Mm.
getting answers from them, I suppose. I don't know.
And some patients become very frustrated that they sit in the dental chair and they ring their CNS and you speak to them there and then. So that's another sort of slight way that you can try and get involved with that MDT kind of approach in a sort of very, very timely way, particularly if the patient's in a lot of pain and they're really wanting something to happen quickly.
Yeah.
But I understand, I've worked in the community setting where we had to take blood days before, and that's challenging. That's really challenging. And that's why there is a place for these patients to be seen in a setting where the care can be done really quickly. I know that doesn't always happen, but there is the high risk patients having high risk procedures need to be seen in the environment where that can be really supported.
Thank you very much, Emily. I just have a few comments about um, how logical and understandable that talk was,
Thank you.
and a lot of thank yous as well. But I think that now is a good time to cut it just while I still have people's attention this late into the evening. So thank you very much, Emily, on behalf of the IADH, for a very, very informative talk for our membership here in Ireland. I also want to let you all know that the next webinar is scheduled for the 16th of February. Registration will open in the next kind of week or so, and it's related to the management of implants and failing implants in the older adult. So please do register for that if you are interested. And yeah, that's it really. Thank you very much, and I hope everyone has a lovely rest of your night. And thanks again, Emily. Take care,
Thank you
everyone.
very much.
Bye
Great.
bye.
Thank you so much for a great evening. Thank you, everybody.